Good morning, everybody. My name is Cheryl Kataoka. I'm a professor emeritus here at Summel Institute, which really makes me sound old. It brings me such joy to get to introduce Dr. Misty Richards, who will be talking about her innovative work at the interface between infant mental health and perinatal psychiatry, and why this is an important role for child psychiatrists and all those trained to work with children and parents. I mean, how brilliant is that to be supporting parents at the very beginning of such a critical relationship, that of a mother and her child? And these seeds have been planting a long time in the heart and mind of Dr. Richards. As far back as when she was an undergraduate student, Dr. Richards was involved in research to study better ways to support pregnant mothers with anxiety, depression, and PTSD, which has now become her life's work. But before I get to all of that, I just want to highlight a couple of examples in her long list of accomplishments of some of the ways Dr. Richards fully embraces what she cares deeply about. Early in her career, she studied the genetics of schizophrenia as a research fellow at the National Institutes of Health and National Science Foundation. She was then awarded a Fulbright scholarship to conduct cross-cultural research in Japan, comparing the stigma associated with schizophrenia in the US and Japan. In her free time during medical school, in between classes and research, Dr. Richards co-founded the Ngea Health Clinic in rural Uganda, creating a partnership between local Ugandan leaders and multiple US universities and organizations to expand access to health resources there. And almost 20 years later, they are still going strong. As a faculty member here at UCLA, Dr. Richards has done it all, with many accolades for her teaching of hundreds of medical students and residents. She has been our fearless leader, serving as the director of the Child Psychiatry Fellowship Program for the past 5 years, all the while expanding educational opportunities for our child fellows. She has also served as medical director of infant mental health at the Maternal Mental Health Partial Hospitalization Program. And as she will be sharing with us today, she is co-founder and medical director of Perinatal Psychiatry at the Moms Clinic, a partnership that she created between OBGYN and psychiatry to meet the overflowing need of mothers suffering from mental illness and at the same time being able to support their maternal-child bond. And in true Misty fashion, she has created amazing learning opportunities for our trainees, including a year-long area of distinction elective in parent-infant mental health. There are endless possibilities when you hang out with Misty, so please join me in welcoming Dr. Misty Richards.
Oh my goodness. Dr. Karaoke, I am so honored to have Dr. Karaoke introduce me today. She has been a mentor for as early as I can remember since I started my career here at UCLA. So it's just a privilege to see her here in this capacity. So I'm going to share my screen, hopefully successfully. Okay, hopefully y'all can see that. And today we're going to talk about a topic that is near and dear to my heart. Before we do, I am going to actually stop share and I'm going to share again and I'm going to optimize my sound. Okay. So let me try one more time. Okay, there we go. So this is a topic that has been on my mind ever since I became a faculty member here at UCLA. And we're going to talk a little bit about how to bridge the divide, integrating perinatal and infant mental health, two areas that I believe really are on a continuum. So I'll tell you a little bit about the origin of a clinic that I was so lucky to be a part of creating in the Department of OB-GYN that really is meant to bridge this divide, and also some initiatives we have going on here at UCLA in general and in the community to serve the people during the perinatal period. So I have no disclosures, and here are some of my reasons why. And the reason why I'm sharing this slide from the get-go is sometimes it's so easy to get lost in the work that we do and to wonder why we do what we do. And I always find it grounding to center myself in my purpose, my reason why. And on the left here, at least my left, are my 3 babies who are now 6, 8, and 10. And they teach me and they humble me every single day. And in the middle here is a beautiful picture of just a mother and her daughter, and touching foreheads and truly connecting. And I love how the daughter's eyes are closed and really feeling attached, and hopefully securely attached to her mother. And is this not the goal in life, to feel securely attached wherever you go? And then certainly on the right here, this is an old picture of some of the child psychiatry fellows and graduates who have gone on to do incredible things. Of course, Dr. Kataoka is right in the front there. So these are some of my reasons why. Here are some collective reasons, hopefully our reasons why we do the work that we do. This is a staggering statistic that 4 out of 5 pregnancy-related deaths in the United States are preventable. 4 out of 5, and this is it from the CDC, and this is in 2022. Additionally, I'm just gonna share some kind of staggering statistics here to hopefully get your attention. And this is courtesy of Emily Dossett, who is also a trusted mentor in this space. So we're gonna talk about perinatal mood and anxiety disorders today, just gonna call it PMADS. And we're gonna talk about how they are the most common complication of childbirth. And when you say that out loud and you repeat it, PMADS are the most common complication of childbirth. Almost everybody will be touched by this in some capacity, whether it's yourself, whether it's a friend, whether it's a family member. So perinatal depression, up to 40% of Black women suffer from perinatal depression. 1 in 3 Latina women, 10 to 20% of Caucasian women. And then perinatal anxiety affects 1 in 5 postpartum individuals. And just as a reminder, perinatal anxiety is not a freestanding diagnosis in the DSM. It's a compelling symptom of major depressive disorder with peripartum onset, which we'll talk about in a moment. And you compare this to other obstetrical complications like preeclampsia, which is an absolute emergency, which is 9%, gestational diabetes, 7%, and postpartum hemorrhage, which is 3%. And you'll see that the percentages of PMADS are significantly increased compared to these other obstetrical complications, which, preeclampsia, usually babies are delivered early and weighing less with preeclampsia. Here's some more staggering statistics. This is from the California Pregnancy Associated Mortality Review Report, published in 2019. Suicide and overdose are the #1 cause of death for perinatal people in California. 99 women with death attributed to suicide and or overdose. 83% passed away in the late postpartum period, which we're defining as 7 weeks to 1 year postpartum. 62% had a mental health diagnosis before pregnancy, so could have been caught earlier, and 25% new onset in the postpartum period. What were the diagnoses? Depression in about 54%, psychosis in 24%, bipolar disorder 17%. And many of these individuals had co-occurring substance use disorder, about 32%, and heavy alcohol use, about 17%. 83% had intense psychosocial stressors. And this is certainly, even prior to COVID that these statistics were gathered. 51% had a good to strong chance of suicide preventability with missed opportunities to intervene. So these are part of our collective reasons why we are here today. What's happening in Los Angeles County? So I think a lot of people think that in LA County, we have, multiple resources. We have a lot of providers and we are doing good work, yes. But if you think about the population that we are to treat in this, great population we're asked to treat in the perinatal period, you will find that if you go to the Policy Center for Maternal Mental Health, and this was gathered in May 2025, that we are number 2 in the country of counties with the lowest resources for the perinatal population. That is wild to me. So in Los Angeles County, we have 202 perinatally trained providers, and this just doesn't include just psychiatrists. This is all providers that have a certification. The number of required providers is 454. So the gap in providers is 252. And this is again number 2 in the country. So we have work to do to not only train up the people that are graduating from our programs, but again, also to figure out new innovative ways to provide access to care and treatment. And then certainly from the child psychiatry perspective, and this is again why we're here today to talk about this continuum of care, if PMADs are left untreated, they can have a multi-generational impact. So what are we going to hope to talk about today? It's pretty ambitious, but we'll get as far as we can. We're going to talk about how relationships matter. We're going to talk about a word that I hope everybody walks away not only knowing, but applying in the care that they provide, which is called matrescence. We're going to talk about perinatal mental health and how it really is synonymous with infant mental health. They're one and the same. We're going to talk about how to make the diagnosis of perinatal mood and anxiety disorders, including major depressive disorder with peripartum onset, which is the new DSM way to classify postpartum depression, because we know that symptoms start and can start during pregnancy, not just in the postpartum. We're going to talk about treatment, and we're going to talk about the impact on children and really kind of multiple generations. We're going to also talk about the dyadic approach to treatment, specifically focusing on attachment. And then we're going to talk about really innovative ways to approach, opening access to care and broadening services for this population. We'll talk a little bit about how the Moms Clinic was created and what we do. And then we're going to talk about a program called Promise, as well as CalMAP. And then I'd like to introduce a Perinatal Infant Mental Health Network that was just created this past spring that I'm lucky enough to be a part of. Okay, so first, a video that I hope to share.
Take the next step in treating your moderate to severe ulcerative colitis with Entyvio, the only gut-focused.
Yo, comedian Michael Jr. here. As you know, I just flat out enjoy doing comedy. But one of the things I love way more than that is being a dad. Not too long ago, I'm going through some video footage and I run into this video of my youngest daughter being born. Now, of course, I was there. I actually took the video, but I had never really experienced it from this perspective before. Now look, we're in the hospital room. She's sticky and she's baby and all that stuff, and she's in the middle of crying. And then I speak up. I start talking to her, and watch how she responds when she hears my voice.
Temperature.
It's okay, Portland. Look, I'm right here. It's okay. It's okay. I'm right here. I'm right here. We're doing just fine. It's okay. It's okay. I'm right here. Right here. Yeah. It's okay. It's okay, baby. It's okay.
That was pretty awesome. So check it. A few minutes later, the nurse starts working on her, puts her pamper on her, and I'm not saying anything, and she actually starts to cry again. Then I speak up, she hears my voice, and stops crying, like again. But I want you to notice what else happens after I tell her that I love her.
Portland, Portland, it's okay. It's okay. It's good. It's good. It's good. I'm right here. I'm right here. I am right here. I love you. I love you. I love you. Yeah, I'm right here. I'm right here. It's okay. It's okay.
That's just phenomenal. I'm like, whoa.
That video never gets old. And this is a video that illustrates that relationships start early. His beautiful daughter was able to recognize his voice. And then certainly by the tone of his voice, when he says, I love you, begins to search to try to connect and find him. And I love the way that he narrates this because he's a funny guy. And this video just never gets old.
Here.
Okay. So let's talk about moms. What about moms? And for sake of simplicity for today's talk, we're going to call folks moms, okay? Let's talk about the perinatal period. So what is the perinatal period? It is a time period during pregnancy and up until 1 year after delivery. So really it's a 2-year period of time. This is the word that we talked about earlier, which is matrescence. And I hope everybody is able to not only learn the word, but apply it in the care that you provide from this day forward. So it sounds a lot like adolescence. The word is matrescence, and it's defining the birth of a mother. So it's an identity shift, and there really is no destination, right? It sounds like, again, adolescence, maternal matrescence, and really with the birth of any baby is the birth of a mother. So this was a term coined in 1973, of course, by a medical anthropologist named Dana Raphael, and it discusses this body morphing and hormone shifting, and that leads to an upheaval on how a person feels emotionally. And it is this emotional tug of war that really describes this kind of push and pull concept. So this pull from oxytocin produced in your posterior pituitary to become the mother of your wildest dreams, maybe the mother that you always thought you wanted as a child. And then this push to keep the other parts of your identity intact that you don't necessarily want to sacrifice. And this is a dynamic process, ever changing, and certainly tethered to the developmental trajectory and stage of your child. So again, this is not pathology. This is not postpartum depression. This discomfort is not the same as disease, okay? Postpartum blues, also not pathology. Up to 80% of women experience postpartum blues. I'm just saying, women for sake of simplicity for this talk. 4 out of 5. That is a very high number, and it is a rite of passage into motherhood as far as I'm concerned. So again, it's not in the DSM, really kind of minimal impairments in functioning, tends to peak on the 4th and 5th day after delivery, and then tends to get better or even remit spontaneously within 2 weeks, okay? Sometimes it's not always perfect that way, but it tends to trend in a positive direction of recovery. What are the symptoms? So movability, tearfulness, tends to be extreme anxiety, maybe difficulty falling asleep because of that. And sleep is always a foreign concept during this perinatal period. And then of course, if you're not getting sleep, leading to irritability, and it doesn't have to necessarily mean sadness. Now, what happens if those symptoms don't get better and in fact get worse? It could meet criteria for the DSM-5, major depressive disorder with peripartum onset. That is the new name for postpartum depression, though colloquially and in the media, you'll see postpartum depression. And certainly if symptoms start after labor and delivery, then it can be postpartum depression. The classification according to DSM-5 is major depressive disorder with peripartum onset. So this is a very important statistic. 39% who experience depression during pregnancy go on to develop postpartum depression. 39%. Up to 7-fold risk among women whose depression is not treated during pregnancy. So hopefully I'll make a strong case today to really consider treating during pregnancy, and there are multiple ways that we can treat, not just psychopharmacologic. So really staggering high statistic in medicine, up to 20%, and this is, we talked about Caucasian women, specifically in many of the studies study Caucasian women, suffer from MDD with peripartum onset. It typically emerges over the first 2 to 3 postpartum months, though according to DSM, it's usually within the first month, though we know clinically sometimes things don't always fit beautifully in boxes that way. What are some of the causes? Not the one cause, but a major contributing cause is a sensitivity to hormonal shifts. So clinically, if you're seeing folks in this population, ask them about how they tolerated their menstrual cycle, specifically the luteal phase, which is the week before menstruation, because that is a litmus test for how one may tolerate, hormonal shifts in their body. What are some of the risk factors of MDD with peripartum onset? Depression during pregnancy, we just discussed, history of depression, bipolar disorder, or certainly a prior history of MDD with peripartum onset. It's like flipping a coin. It's about 30 to 50% chance that it'll occur with a subsequent pregnancy. And then certainly a family history of mood disorders. Also another risk factor, stressful life events or lack of support. A common question I get asked is what happened after COVID? And you better believe that there was a rise in terms of the folks who were presenting to the Moms Clinic and really kind of throughout the country. There's a societal burden of $14 billion in the United States per year because many folks suffering from this disorder, it's very difficult to re-enter the workforce because it's a very sticky diagnosis. We must do better. We must do better. And so this talk is also in part advocacy for doing better. And I would say that, these recent publications came out from OB-GYNs and cardiologists. And here are the kind of a screenshot of these studies, and here's kind of the fundamental truth as it stands. Universal recurrent screening and timely intervention for perinatal mental health are essential and evidence-based. So this is an access to care issue. Perinatal mental health is a key determinant of maternal and infant outcomes. And this is including cardiovascular health, and it requires an integrated multidisciplinary approach to care. We must address health equity, social determinants, and community engagement is absolutely critical if we are going to make a dent and really do the good that we want to do. Here's a great memoir that if you're looking for a quick but really powerful read, this is written by Teresa Wong, and it's Dear Scarlett, the story of my postpartum depression. And here is a picture of her mind and some of her cognitive distortions, and which actually did improve with cognitive behavioral therapy. And I'll read some of them out loud. All the other moms can do it. Why can't I? I'm a bad mother. I am so tired. I just want to disappear. This is too hard. And if you're having these cognitive distortions and feeling inadequate, it can be very hard to parent and become mother. This is actually an op-ed piece written in the LA Times by a patient of mine, Deborah Herbert, and I have her permission to share this. And obviously it's published in the LA Times. Op-ed piece. My postpartum depression was not hard to predict, yet no one warned me. The first time I held my daughter, instead of feeling boundless joy and radiant love as I'd expected, I was overwhelmed with fear and remorse. I had the sense I was drowning in mud, holding her over my head. I thought for sure we'd both go under. Once we got home with the baby, I was so overwhelmed with obsessive anxiety that I couldn't properly care for her. Here's the final video, but this is also just a very potent illustration of what postpartum depression or MDD with peripartum onset can look like.
Build a website you love with Wix, where your words
what a night nanny is. They take care of the baby at night so mom and dad can get some sleep.
I don't want a stranger in my house. It's like a Lifetime movie where the nanny tries to kill the family and the mom survives and she has to walk with a cane at the end.
Get over yourself.
Mom, what's wrong with your body?
Hello. I'm Telly. I'm here to take care of you. I'm just not used to people doing things for me. I hold a baby all day, and then nighttime rolls around and I'm supposed to just switch gears, like, hello, I'm all sexy now. You're empty. Yeah. No, you're empty on this side. Your 20s are great. But then your 30s come around the corner like a garbage truck at 5 a.m. Girls heal. No, we don't. We might look like we're all better, but if you look close, we're covered in concealer. You're convinced that you're this failure, but you actually made your biggest dream come true.
If you want to run off or something, I get that, because I want to do that too sometimes, but I'm not gonna.
I'm here to help you with everything. You can't fix the parts without treating the whole. Yeah, no one's treated my whole in a really long time.
Okay, so that is a movie that came out in 2018, and there's a plot twist at the end. This is a great portrayal of the symptoms that come with major depressive disorder with peripartum onset, though that is not actually the diagnosis she has. Okay, so what are some of the causes of MDD with peripartum onset? Let's get into the science here. So there's a rapid shift in the hormonal environment during pregnancy. So HCG spikes, that's what kind of the pregnancy tests detect. And then in comes estrogen, progesterone, and allopregnanolone, which really kind of the greatest delta in terms of growth is around 24 to 28 weeks of pregnancy as women gallivant into the third trimester of pregnancy. What happens if people have a sensitivity to these hormonal shifts? Well, it can be very hard, and that can be kind of the precursor to an MDD with peripartum onset. So what happens within the first 48 hours after delivery is that estrogen, progesterone, and allopregnanolone drop to pre-pregnancy levels in an unforgiving Magic Mountain roller coaster ride. And so this is incredibly challenging for anybody to navigate. It's why the rates certainly of postpartum blues are so high. But if you have a unique sensitivity to hormonal shifts, this can develop into an MDD with peripartum onset. So we discussed this a little bit before, but what are some of the risk factors? So depressive symptoms during pregnancy. So we can get ahead of this during pregnancy, and then I argue even more kind of upstream is the luteal phase during the menstrual cycle. A personal history of a mood disorder, personal history of MDD with peripartum onset, family history of affective disorders, lack of partner support, and then recent stressful life events like COVID or fires. So a word about anxiety. Does postpartum anxiety exist in the DSM-5? No, it doesn't. It is a very compelling symptom of MDD with peripartum onset. In fact, I talk about kind of the most compelling symptoms as being 2 A's. So what are those 2 A's? The first one being anxiety, and the second one being agitation. And they are neighbors on this continuum of symptomatology. So anxiety is often comorbid with MDD with peripartum onset, and there is no official DSM-5 diagnosis. Some anxiety is healthy, as we know, and to be expected, but it can quickly become pathologic. And the sooner we can catch it, the sooner we can have impact and really help this mother engage with her child and herself. So most important thing, focus on the level of impairment always. Ego, dystonic, intrusive thoughts, unless you specifically ask about these, oftentimes women will not disclose these ego, dystonic, intrusive thoughts, which are not uncommon, specifically during the postpartum period. So ego, dystonic, mean it's foreign, it's to your sense of self. It's like, this is weird. Why am I thinking this? You have some insight. Intrusive means it can come at inopportune times. Thoughts, meaning they're in your head and not necessarily impacting behavior. If there's an impact on behavior, then it becomes an emergency most of the time, okay? So here are some actual quotes from patients of mine. I repeatedly imagined running over my son with my car in excruciating detail. My thoughts would haunt me. I felt trapped. I pictured myself standing on the balcony with my baby and then dropping her. I would cry at night because I imagined walking in to see my baby in her crib after suffocating. I keep seeing her lifeless body every time I close my eyes. So as you can imagine, sometimes it's hard to disclose some of these thoughts for fear of having your baby taken away, being judged, or being seen as inadequate. So I encourage you to gently ask about some of these, the possibility of ego, dystonic, intrusive thoughts once you've established trust with your patient. So what's it look like parenting with postpartum depression? And this was a study done in 2012, a seminal paper showing that mothers with postpartum depression demonstrate more anxiety, parenting difficulties, which make a lot of sense. If you're not feeling good, how are you going to care for another human if it's really hard to care for yourself? And then certainly the mother-infant attachment can be compromised. And again, attachment can't be reliably measured until about 12 months of age. Only 1 in 10 mothers receive evidence-based care. And there's just, 10 years in terms of a loss of quality adjusted life. So what about children? Again, I'm a big fan of just like staggering statistics. So just to make sure that our eyes are open, 90% of a child's brain development happens before age 5. So early childhood mental health is critical. The part that is purple is the prefrontal cortex. And just so you know, in utero, when does the prefrontal cortex begin to form? And we just talked about this in the parent-infant area of distinction. It's about 7 to 18 weeks in utero. So kind of really that first and second trimesters when you're building the basics, the fundamentals, the foundation of a baby's brain. And then 90% is built by age 5 with the prefrontal cortex being myelinated and further developed up into the 20s. There are these sensitive periods in early brain development where significant amount of synaptic pruning occurs. And it's really important to pay attention to this because, neuronal connections, if you don't water and nurture them, they can be pruned away. And we really want to think about how to invest in our children as early as we can so those important neural connections are not pruned away and in fact are further developed. So what's the impact of maternal depression on children? So children of depressed mothers show greater vulnerability to, of course, depression and anxiety disorders. Part of that, meaning nature and nurture, neurocognitive deficits and maladaptive social behavior, because there is a need to regulate. And if the mother or the family is not regulated, it can be really hard for a child to learn and practice regulation. And then, of course, difficulty with self-regulation or self-soothing. And we know that, a baby can begin self-soothing as early as 4 months, postpartum, 4 months of age. They can begin learning to self-soothe, and it's such an important investment to help them learn how to do that because we aren't always going to be there for our children as caregivers out in the wild. So the transmission of risk involves, of course, genetics, and then further epigenetics, meaning how the environment shapes the expression of our DNA, and then certainly detached parenting that negatively impacts the attachment relationship. And we just published a study, which I could share at part 2 of this talk at another day, is that really mothers' perceptions of parenting are wildly influenced by postpartum depression and their ability to treat it or not to treat it. And if it's not treated, it can really impact their perception of how they parent. So focusing on infants, untreated postpartum depression can have negative effects on maternal responsivity, so that reciprocity that we want to see between caregiver and baby. The attachment style, compromising secure attachment, which can be measured only at 12 months of age, beginning at 12 months of age. Infants raised by mothers with depression can also show early disruptions in social and emotional development, and more negative affect and difficulty self-soothing, because unless it is practiced regularly, it's hard to put it into practice in life consistently. So the bottom line is treat mothers early while also addressing the dyad. It is part of the mother's mental health. It is part of the child's mental health. They are one and the same. What is the definition of infant mental health? So the developing capacity of the child from 1 month to 1 year of age to experience, there's that word again, regulate, and express emotions, form close and secure relationships, and explore the environment and learn. And you have to feel safe in order to explore the environment, and you have to feel safe in order to learn in any environment at any stage of life. So the most important thing to think about here are consequences of early adverse experiences are substantial. So I think by now we all have heard of the infamous ACEs study that was done in 1998, showing that early adversity has lasting impacts. So it is an important predictor of outcome, the amount of stress in an individual's early life. The number of ACEs tends to predict health outcomes in adulthood. So the more ACEs that a child has, the greater it can impact their overall health, not just mental health, including physical health. So interventions supporting the infant-parent relationship are the most effective way to promote health in families to have a 2-generation impact. What are some long-term child outcomes? Another seminal paper in 2018 by Netzi et al. So this is an observational study of about 10,000 women with postpartum depression and about 8,000 of their offspring. Children of women with persistent and severe depression were at increased risk for behavioral problems, their child, by age 3.5 years, tethered to difficulty self-soothing. And if there's a difficulty self-soothing, it can manifest as externalizing behaviors at the age of 3.5 years old that all of us who have parented toddlers are well aware of. Lower math scores at 16 years old. It can be very challenging to access your prefrontal cortex, which is the part that does the thinking and the executive functioning, if you are stuck in your brainstem or your amygdala, really trying to learn how to regulate or feel safe in a learning environment. So this is why there can be impacts on neurocognition over time. And then depression at 18 years of age, which can be, in part, nature and nurture. What about the treatment? What do we do to treat the dyad? So first, let's just take a look at how we treat MDD with peripartum onset. So before initiating treatment, always rule out medical causes. There have been many, many women who have seen me who have had issues with their thyroid that have gone misdiagnosed. And I urge you all just to take that second to go back to Medical School 101 and rule out thyroid dysfunction. The rates of postpartum thyroiditis are as high as 8% after labor and delivery, which initially can present as a hyperthyroidism, anxious, revved up state, and eventually land on a hypothyroid state, which can feel like a slowing and give a depression picture. So make sure you're ruling out, thyroid dysfunction as well as anemia, first and foremost. Make sure that you're educating and you're normalizing. This is an incredibly common the most common complication of childbirth, and reassure the family and the mother as much as you can with some statistics of how people tend to get better, and talk about support and attachment and really kind of addressing the dyad, because underneath this fear that most women with MDD with peripartum onset have can be this fear that they are wildly inadequate to do the job that they are tasked to do. Psychotherapy, challenging those cognitive distortions with CBT, and then interpersonal therapy. These are the two evidence-based modalities for this population. And then certainly antidepressants, which tend to be the gold standard, are selective serotonin reuptake inhibitors, of which Zoloft and Lexapro tend to be tied for first because they cross over to baby in utero in really low amounts, and also to breast milk postpartum in really low amounts, virtually undetectable in the baby if the mother decides to breastfeed. And then hospitalization, if symptoms are severe, suicidality is on the table, or ego dystonic intrusive thoughts that tend to turn into impacting behavior. CBT, this is a really powerful study done in 2021 showing that a 1-day intervention provided to new mothers from 9 to 4 p.m. Really helped. It was an interactive workshop, a lot of teaching, a lot of processing in group exercises, focusing on the etiology of postpartum depression, development of cognitive skills, including cognitive restructuring, behavioral skills in terms of problem solving, behavioral activation, and then goal setting. So the results were that this 1-day CBT workshop reduced postpartum depression and anxiety, as well as improved social support, because these mothers knew how to ask for it. Just want to do a quick word here on zuranolone. This is an FDA-approved, the only FDA-approved medication for postpartum depression specifically, and it just garnered this FDA approval. And a very important paper, if you want to learn more about the science behind zuranolone, was published in 2023 in the Green Journal, American Journal of Psychiatry. What is zuranolone? It is a neuroactive steroid and positive allosteric modulator at the GABA-A receptor. It's a lot of words. It functions almost like a benzodiazepine, not identically, but close. The mechanism of action, just like a benzodiazepine, is it modulates the GABA-A receptor. If you'll remember, GABA is the major kind of neuroinhibitory neurotransmitter in the brain. Why this is a different and unique medication is it is shown that it can have a rapid reduction in depressive symptoms quickly, as early as 3 days, but the median response is 9 days. And you give it for 14 days, so it's almost like a course of antibiotics, and it's a daily pill that new mothers take with severe postpartum depression that is, again, taken orally and not an infusion like brexanolone, which attempted to help in 2019 but failed short because it was too expensive and really hard to administer. What are some of the side effects of this new medication? Somnolence, dizziness, sedation, and headaches, but it's generally well tolerated. I've prescribed it over a dozen times myself for very severe cases of postpartum depression, and I would say that overall, most people responded quite well. I've had a few that had side effects of really intense somnolence and sedation, which is really hard to parent if that's a side effect, and so we discontinued zuranolone because of that. So what happens if you don't treat major depressive disorder with peripartum onset? Put this question here in bold, underlined, primarily because it's something we don't think about. We think about what are all the consequences of treatment, specifically with an SSRI during pregnancy. I get all those questions, and we know that there can be risk of neonatal withdrawal syndrome, treatment with SSRIs, certainly very rarely persistent pulmonary hypertension of the newborn. But what happens if you don't treat? There can be risks of gestational hypertension leading to preeclampsia, leading to early deliveries, leading to babies who weigh less. And we don't think about the cortisol spikes that can accompany untreated MDD with peripartum onset. It's really important to think about this all together and to help the mother feel like she's in her body as she's growing another baby, or growing a baby. So attachment vitamins, I give a lot of credit to Alicia Lieberman at UCSF for the incredible work she's done here. The most important takeaway in terms of this slide is bonding can happen quickly. It is the caregiver's feelings towards their infant. It's through their perspective, whereas attachment is through the perspective of the baby. And that is something that is measured around 12 months of age, and it is earned through kind of warm, consistent parenting over time. So attachment terms that I want you all to know are secure base and safe haven. And so we teach this in the perinatal intensive outpatient program, also in the mom's clinic. And secure base is an opportunity for the mother to serve as a firm trampoline in which their child launches off of them to explore the world. This is kind of that check back that a lot of little ones do to their mother or their parent to be like, is this okay? Is this safe? And if it is safe, you feeling firm as a parent to say, go explore the world, launch and do good things, learn, experience. And then when something happens out in the world, for you as a mother or a caregiver to serve as a safe haven, to welcome any emotion that child brings your way, and to be able to process it and digest it with them and teach them how to cope. And you are doing this interchangeably, this secure base, safe haven in a dynamic way. What happens if you yourself as a mother are experiencing trauma or have experienced trauma? Does that impact your ability to parent? Absolutely. And that's something that is important to address as well. So secure attachment can be measured at about 12 months of age. What is the reason why we care so much about secure attachment? If I could distill it down to one line, it is the foundation of self-esteem for any human. So the more secure attachments you have, the thought is the more secure and the better you're going to feel about yourself as you engage in life. This is a program that we are launching in the Moms Clinic, and we have a study that we just completed on the Circle of Security program in the Moms Clinic, and we have another study that we just completed in the Perinatal Intensive Outpatient program. And this is a program that has 8 modules introduced weekly, and they are to kind of promote reflection amongst the members of the group. And it is, it follows a DVD, and you talk a lot about secure attachment and applications of secure attachment, even if you're feeling depressed and anxious. Bottom line, developmentally focused, relationship-centered approach is the most high impact way to have a multi-generation impact. Here's a schematic of what the circle of security looks like. Again, the secure base and safe haven are the hands, which every caregiver has the opportunity to further develop. And then this cycle represents a moment in a day. So this is happening thousands of times in a day, and opportunities for the parent to serve as a secure base or a safe haven over and over again to help that child find their way to secure attachment. So let's talk for a moment about access to care. This is kind of my thank you, my big thank you slide to the expert team here. Specifically, shout out to Natalie Petrovic, who is the clinical director of the Moms Clinic that is now 6 years old. And this is a collaborative care clinic that was spearheaded by the UCLA Department of OB-GYN, opened the doors in 2019, and I was lucky to be a big part of that process. And why did we open our doors and create this psychiatric urgent care model? Is to provide pregnant persons with timely and affordable access to mental health care during the perinatal period. What are the services that we provide? Full psychiatric assessments, and I get to provide these assessments. We want to reduce the barriers to accessing care, so referrals all come from OB-GYNs here at UCLA, and what we like to think is a seamless approach. About 3,000 new patients have been seen in the Moms Clinic to date, And we have partnered the Moms Clinic with 5 different research groups over time, leading to 15 publications to date. And then we've partnered with 3 LA County community organizations because advocacy is a big part of the work that we do with this population. Here's our vision for the future. Is really to improve upon our screening. And if you remember back to what the OB-GYNs and even cardiologists noticed, was that screening is integral to providing the care that we need to provide to this population by catching things earlier. Here is the data that we collect. Here are the questionnaires that every single patient at every single touch point in our clinic receives. There are 10 questionnaires, and you will see that they aren't just focusing solely on the identified mother. They're focusing a lot on the dyad. And you'll see that with the Adverse Childhood Experiences Scale, the Benevolent Childhood Experiences Scale, Parent Stress Index, Postpartum Bonding Questionnaire. And this is just a pretty picture of the growth in terms of the patients we have seen over time. Just a quick word on this program called Promise that was started by Emily Dossett. And this is a provider-to-provider hotline. So if you are out there in primary care land and you feel lost and you don't know what to do with a patient who may be suffering from MDD with peripartum onset, you can call this number 833-374-4MMH. And on the other line will be a skilled reproductive psychiatrist who will hopefully answer some of your questions. Also, from Petra at UCSF, CalMAP, which is a similar idea, and it's been well established and highly effective for child and adolescent psychiatrists who are on the other end of that hotline for primary care providers who need support and help for this population. And then finally, here's a new initiative that we started, a group of us, so 3 of us, one person at Stanford, one person at Georgetown, and then certainly UCLA represent the Perinatal Infant Mental Health Network. There's a QR code there. If you would like to join the network, we would so welcome it. This is a collaborative hub to break down the silos and have us all work together on research, clinical care, advocacy, and then certainly providing education through modules that we hope to roll out across the country, learning from the great work that the NCRP has already created for us. So what are some take-home points? It's important to identify and treat perinatal mental health disorders early. Early relationships are incredibly important. 90% of the brain develops the first 5 years of life. Secure attachment is the foundation of positive self-esteem. Invest in the dyad for the best outcome for a 2-generation impact. It's important to connect people, systems, and communities in care. It can be hard to do, but we really are breaking down broken systems and trying to create better ones. Caregivers suffering from MDD with peripartum onset who expand mental health services to include their infants have greater outcomes individually and as a dyad. Here's some references, and here's how I hand every single group that I lead.
Wow, thank you so much, Misty. That was just so inspiring and so great to see the amazing work you've been able to, start from scratch over the last, 5 to 6 years. Incredible. We have a couple comments and questions. Please, if you have any questions, do it in the QA. Brandon Ito says, amazing as always, Misty. Is there data on how much difficulty getting pregnant, infertility, or complications during labor affect risk for postpartum depression?
Yes, and that's a really very good question. We know that infertility and certainly struggles with becoming pregnant are a big part of this picture. Have there been beautiful randomized control studies on this? No. But there have been some studies done on this. The N tends to be pretty low, showing that it's incredibly compelling, like up to 60%. So that's the statistic from the most recent paper. There's only a few out there. An invitation, if this is something that calls to you, to do a study on this, because it needs to be done.
Yes. Great, thank you. And Dr. Suma Jacob says, great talk, appreciated all the new updates, Misty, including the new GABA targeting medication. I recall learning about baby blues in first 48 hours, in contrast to postpartum depression. A lot of moms are affected. What can we do to better prepare treatment providers and moms? You mentioned the risk factors like sensitivity to hormonal shifts. Is there follow-up data in national healthcare systems, like in Scandinavia perhaps, that look at outcomes of earlier onset reports or of difficulty with menstrual cycle related mood disorders or history of early depression?
Yeah, it's a really good question. So if folks have PCOS or are suffering from PMDD, premenstrual dysphoric disorder, that's a really, could that be tied to rates of MDD with peripartum onset? And, I will say that we don't talk enough about this exquisite sensitivity to hormonal shifts as almost kind of something that is asked about as a vulnerable risk factor for MDD with peripartum onset. We know that the rates are about 40% if the people are experiencing depressive symptoms during pregnancy. Do we have the number of folks who are experiencing, let's say during the luteal phase, difficulty and the rates that they kind of experience MDD with peripartum onset? There's been maybe 2 studies done, but that would be, and that's actually on the hit list of a study to do, because it would be important to have a larger N, and Scandinavian samples are always, they have those beautiful Ns. So is there a study looking specifically at that with a beautiful N? Not that I know of, but I think we need to think about hormonal shifts and sensitivities, which we're kind of missing it, or we're kind of treating downstream impact as opposed to upstream.
Finally, Dr. Natalie Ramos has a question. What is your opinion on switching antidepressants in folks who are relatively stable but high risk for recurrence and become pregnant? I.e., would you switch?
Yeah, my co-chief back in the day, Natalie Ramos. Yeah, the party line is this, is that if someone's doing well on an antidepressant and they become pregnant, that you keep them on that antidepressant, whether it's an SSRI, SNRI, or Wellbutrin, and Wellbutrin's a DNRI. So you keep them on that, you don't disrupt. A lot of people who do know the data and are pregnant, and if say they hear about sertraline crossing over or escitalopram crossing over in lowest amounts, will want to shift to that antidepressant. It's not what you're really kind of supposed to do, but I will say if they are absolutely adamant, you can share the data with them. There are, it's true, Wellbutrin and SNRIs have not been studied as much, so we don't have as much data. So if they have informed consent and they want to switch, you can do it, but it's risky. I would not advise doing that. I would advise staying on the antidepressant that they're on and then having them maintained on that dose throughout pregnancy and then in the postpartum.
Great, thank you so much. We're at our time. I did want to slip in my question, which is, with all the success at UCLA and building up this mom's clinic and all the different services you provide, any thought to disseminating it across LA County to really knock down that, disparity gap that we saw in the first few slides, right? And the 40% of African-American women that have major depression during pregnancy.
Cheryl, I need your help. Dr. Kataoka, I need your help. But that, this could be another part 3, the access to care. So you saw Emily Dossett and you saw Petra, and those were in talks, and that is especially Emily Dossett and the good work she does with USC and then LA County to be a part of that promise line to provide support to the people who are doing the good work in primary care settings, to support them knowing that it's going to be hard to train up and provide and fill that gap in providers in the next few years. So instead of waiting, let's get innovative and let's think differently and just provide the supports to the people through a program that exists courtesy of Emily Dossett called Promise. That's one step in the right direction. We have 3 partnerships, and with community folks about how to provide education to give the power back to the providers who aren't always physicians and many times are not, and who are doing home visits, because that's always the gold standard, home visits.
Yes. Yes. Well, thank you so much for all of your wisdom. Definitely, there's like 2 or 3 part 2s and 3s of this grand round. So much good work. Thank you so much, Dr. Richards. And thank you everybody for attending. We'll see you next time.
Thank you.